That is where the aspirin story becomes much more complicated and much more important to understand. The goal is not simply to decide whether aspirin is good or bad. The real goal is to understand the balance between clotting risk and bleeding risk, because both can cause serious harm. A medication that lowers the chance of one problem can sometimes increase the chance of another. Good prevention means finding the balance that makes sense for the individual. This is especially important as people get older. Age itself does not automatically mean someone needs aspirin, but aging can change the equation. The likelihood of cardiovascular disease generally rises with age, while the risk of gastrointestinal and other forms of bleeding can also increase. That is one reason why broad recommendations for healthy adults I become more cautious. If a person has no established cardiovascular disease, the expected benefit from aspirin may be relatively small, while the potential bleeding risk may become more meaningful. This is also why the phrase baby aspirin can be misleading. The word baby makes the medication sound almost harmless, as if it was simply a weaker version of a normal pain reliever. But low-dose aspirin is still a medication with real effects on the body's ability to form clots. An 81 milligram tablet is smaller than a typical adult dose, but smaller does not mean risk-free. For someone who has been advised to take low-dose aspirin because of established cardiovascular disease, the medication may be an important part of preventing another event. But for someone who has never had cardiovascular disease, taking aspirin without medical guidance may provide little benefit and create unnecessary bleeding risk. This distinction is particularly important because people often make medication decisions based on stories from friends or relatives. Someone might say, "My father has taken aspirin every day for 20 years, so you should take it too." Another person may say, "My doctor told me to stop aspirin, so nobody should take it anymore." Both statements miss the central issue. The correct decision depends on why the medication is being used. Now consider what happens during an actual suspected heart attack. This is different from taking aspirin every morning for years as a preventive measure. If a person develops symptoms that could indicate a heart attack, the priority is emergency medical care. Calling emergency services and getting evaluated quickly is essential. In some circumstances, an adult dose of aspirin may be recommended if the person is not allergic and has not been told to avoid it, but aspirin should never be treated as a replacement for emergency care. The reason is straightforward. A heart attack can be life-threatening, and time matters. The faster the person receives appropriate evaluation and treatment, the better the chances of limiting heart muscle damage. Aspirin may be one part of the response, but it is not the entire treatment. This is an important distinction between emergency treatment and long-term prevention. During a suspected heart attack, aspirin may be used because the immediate concern is a potentially dangerous clot. In long-term primary prevention, however, the calculation is different. A healthy person is not currently experiencing a clot, so the expected benefit of taking aspirin every day must be weighed against the possibility of causing a serious bleed. That difference helps explain why recommendations can appear contradictory when they actually are not. The same medication can be appropriate in one situation and inappropriate in another. Now let's return to plaque, because understanding plaque is central to understanding cardiovascular risk. Arteries are not simply rigid pipes that slowly fill with grease. The arterial wall is living tissue. Plaque develops within that wall through a complex process involving lipoproteins, immune cells, inflammation, connective tissue, and changes in the structure of the vessel. Some plaques are relatively stable. Others can become vulnerable. A vulnerable plaque may have a thin protective covering over an inflammatory core. If that covering breaks, the contents can come into contact with circulating blood. The body responds as though there has been an injury, and platelets can begin attaching to the area. The coagulation system can then strengthen the developing clot. This sequence is one of the major pathways behind acute coronary events, and this is why the degree of narrowing alone does not tell the entire story. Imagine two people. One has an artery that is narrowed significantly, but has a relatively stable plaque. Another has a smaller plaque that is more biologically active and vulnerable to rupture. The second person may still face a serious event, even though the artery is not severely narrowed. That does not mean the amount of blockage is irrelevant. Severe narrowing can absolutely cause symptoms and reduce blood flow. But it means that looking only for a major obstruction can miss another important mechanism of heart attack. This is also why cardiovascular prevention cannot depend entirely on waiting for symptoms. By the time someone develops chest pressure during exertion, shortness of breath, or another sign of reduced blood flow, the underlying disease may already have been developing for years. Prevention works best when risk is recognized before the first major event occurs. That is one reason doctors look at risk factors such as blood pressure, cholesterol, diabetes, smoking, family history, age, kidney function, physical activity, and other medical conditions. Depending on the person, additional testing may also be useful. One test discussed in the original story was SIMT, or carotid intima media thickness testing. The basic idea is to use ultrasound to examine the walls of the carotid arteries. It can provide information about the structure of the artery and may reveal abnormalities that are not obvious from symptoms alone. However, it is important not to treat any single test as a perfect answer. Modern cardiovascular risk assessment uses a broader collection of information, and the usefulness of a specific imaging test depends on the individual situation and current clinical guidance. The same caution applies to online claims about clearing your arteries. You will find countless products promising to clean arteries, dissolve plaque, or naturally unclog blood vessels. These claims often make cardiovascular disease sound like a plumbing problem. But arteries are biological structures, and established atherosclerotic plaque is not something that can simply be flushed away with a drink, herb, or supplement. Some treatments can reduce cardiovascular risk and, in certain situations, slow or partially reverse aspects of plaque development. But that is very different from physically washing plaque out of an artery. This is where lifestyle becomes so important. If someone has cardiovascular risk, one of the first questions should be whether they have once the platelets have created that initial lattice work. That difference is critical because it explains why a medication that can be useful for certain cardiovascular conditions may not be the right answer for another one. Aspirin mainly affects platelets. Anticoagulant medications work on different parts of the coagulation system, and that distinction becomes especially important when atrial fibrillation is involved. For people with atrial fibrillation who need protection against stroke, doctors may prescribe a class of medications commonly called direct oral anticoagulants, or DOAC. You may also hear the older term NOAC, meaning non-vitamin K oral anticoagulants. Examples include medications such as apixaban and rivaroxaban. These drugs do not simply make the blood thin. Instead, they interfere with specific proteins involved in clot formation. Some target factor XA, while others target thrombin. By acting deeper in the coagulation process, they can reduce the formation of the types of clots associated with atrial fibrillation more effectively than aspirin. That is why someone with atrial fibrillation should not assume that taking a daily aspirin is an adequate replacement for an anticoagulant prescribed for stroke prevention. This is one of the most important lessons in the entire aspirin discussion. The right medication depends on the reason a person is at risk of forming a clot, and this is also where people can get into trouble with natural blood thinners. There are many supplements and foods that are described online as natural alternatives to prescription medications. Fish oil, for example, can influence platelet function. Omega-3 fatty acids have been studied for their effects on cardiovascular health and blood clotting. Other substances frequently mentioned include garlic, ginger, turmeric, nattokinase, and seraptase. These compounds may have biological effects, but that does not mean they can safely replace a medication that has been tested specifically for preventing strokes in people with atrial fibrillation. That distinction is easy to miss. Something can have an effect on platelets or clotting in a laboratory and still not provide the same protection as a proven prescription treatment in real patients. The question is not simply whether a substance can influence clotting. The real question is whether it reliably prevents heart attacks or strokes without creating unacceptable risks. That is why cardiovascular prevention should never become a contest between natural and medical. The goal should be effective prevention based on evidence, individual risk, and the patient's circumstances. Prescription anticoagulants are not risk-free either. They can cause bleeding, and that risk needs to be considered carefully. But for a person with atrial fibrillation who has a sufficiently high stroke risk, the potential benefit of anticoagulation can outweigh those risks. The decision should be made with a healthcare professional who knows the person's medical history, age, kidney function, bleeding risk, other medications, and overall stroke risk. This brings us back to a broader principle. Aspirin is a tool, not a universal answer. It can be useful in specific circumstances, but taking it simply because someone says everybody over a certain age should be on baby aspirin is not a sound approach. At the same time, stopping aspirin suddenly because you read a headline saying it is no longer recommended for heart prevention can also be the wrong decision, particularly if you have already been prescribed aspirin because of established cardiovascular disease. Anyone already taking aspirin for a previous heart attack, stroke, stent, or other cardiovascular condition should speak with their clinician before making a change. The reason it was prescribed matters, and there is another cardiovascular risk factor that makes this story even more interesting. Lipoprotein A, commonly written as Lp(a). You may not have heard of Lp(a), but it has been recognized as a cardiovascular risk factor for decades. It is related to LDL cholesterol, but it has a distinct structure and is strongly influenced by genetics. Some people inherit elevated Lp(a) from their parents, and unlike many lifestyle-related risk factors, diet and exercise do not necessarily bring it down substantially. One reason Lp(a) has received more attention is that people can appear remarkably healthy and still carry elevated levels. A well-known example involved Bob Harper, the fitness trainer associated with the television program The Biggest Loser. Harper experienced a heart attack despite being relatively young and physically fit. His experience helped draw public attention to the fact that looking healthy on the outside does not guarantee that cardiovascular risk is low. In cases like this, the question becomes, what risk factor was missed? For some people, the answer can include inherited conditions such as elevated Lp(a). Having elevated Lp(a) can increase the likelihood of cardiovascular disease, although the exact level of risk varies from person to person and depends on other factors as well. This is another reason cardiovascular prevention cannot be reduced to weight alone, exercise alone, or a single cholesterol number. Someone can exercise regularly, maintain a healthy body weight, and eat a relatively good diet while still having inherited cardiovascular risk. On the other hand, someone with several risk factors may be able to substantially reduce their overall risk through lifestyle changes and appropriate medical treatment. The important point is to identify the risks that actually apply to you, and that brings us to one of the biggest mistakes people make when discussing aspirin. They focus on the pill instead of the entire cardiovascular picture. Aspirin does not remove plaque from your arteries. It does not reverse diabetes. It does not automatically lower LDL cholesterol. It does not correct high blood pressure. It does not eliminate atrial fibrillation. And it certainly does not cancel out smoking, poor sleep, physical inactivity, or an unhealthy diet. Aspirin can affect platelet activity, but cardiovascular disease is a much larger process. Think about what happens over years. Blood pressure can gradually damage the inner lining of arteries. LDL particles can enter the arterial wall. Inflammation can contribute to plaque development. Metabolic problems such as insulin resistance and prediabetes can add to the overall risk. Smoking can damage blood vessels and accelerate atherosclerosis. Genetics can influence cholesterol levels, LPA, and susceptibility to certain cardiovascular conditions. All of these factors can interact. That is why lifestyle remains one of the most powerful foundations of prevention. Managing body weight when appropriate, staying physically active, eating a nutrient-rich diet, avoiding tobacco, controlling blood pressure, monitoring cholesterol, recognizing prediabetes, managing diabetes, sleeping adequately, and following treatment plans can all contribute to lowering cardiovascular risk. Medication can be extremely important, but it should fit into that larger strategy rather than replace it. There is also an important difference between identifying risk and actually diagnosing disease. A screening test can sometimes reveal that someone has a higher probability of cardiovascular disease, but no single test can predict the future perfectly. Even imaging tests have limitations. A good prevention strategy combines medical history, physical examination, laboratory testing when appropriate, imaging when indicated, family history, lifestyle factors, and the person's overall risk profile. That is why the question should not simply be, should everyone take aspirin? The better question is, what is my cardiovascular risk? What is causing that risk? And does aspirin provide